Respected audience, my senior teachers here, colleagues, friends, ladies and gentlemen, I consider it a great privilege for having been invited to deliver the Dr. R.J. Katrak Oration 2022. Of the many orations and plenary lectures I have given, I consider this the most prestigious because this is my home ground. This is where I have grown, where I have worked, where I have toiled, So this is obviously the most prestigious oration that I will ever deliver. This oration is dedicated to my first orthopedic mentor, Dr. J.C. Tarapurwala. In 1979, I was a houseman with him. At the end of the term, I felt I was in a different plane altogether. I wrote for him, "You, the vast ocean of which I drank, appear vaster with every drop I drink." Now, I want to speak on the legacy of Dr. R.J. Katrak, and this legacy is very much alive. You all are a witness to the life of this legacy. So, in honor of Dr. Rustam Jamshedji Katrak, he was the torch bearer, and for torch bearers, this is what I have written. Pages of history, a story tell, immortality is born of mortal man. So the first true orthopedic surgeon of India, this is the story of Dr. R.J. Katrak, the man, his life and travails. It is said that chance favors the prepared mind. Dr. Katrak was born on the 23rd November 1903. He died on 8 December 1987 at the ripe age of 84 years. He had done his BA and BSc. He was MBBS from Grant Medical College in 1927. Little did he know that he was to become an orthopedic surgeon. As a child, he never even fathomed, that he would become a doctor or become an orthopedic surgeon. After 1927, while he was searching for jobs, he finally landed up at the Wadia Children's Hospital in 1929 as the first resident surgical officer. There he saw many deformed children and did not know what to do for them. On the suggestion of a friend of his, he wrote to Sir Robert Jones to help him with books and material, and Sir Robert complied, So this is really speaking very high of Sir Robert Jones, that he wrote to an ordinary surgeon in training, writing from India, and he sent him a big parcel of all his books and all the papers that he had ever published. And this is one of the gifts from Sir Robert Jones to Dr. Katrak, Injuries to Joints by Sir Robert Jones. Very serendipitously, Dr. Katrak learned from a friend that a scholarship was being offered by Sir N.S. Wadia for training in orthopedic surgery at Liverpool. To cut short a long story, he applied and went to England on 10th December 1931, landing around Christmas, because those days they used to go by ship. He did his FRCS and MCH Orth in Liverpool in 1932. He was the second Indian to pursue the MCH Orth. He worked under Professor T.P. McMurray of McMurray Osteotomy fame, who advised him to practice pure orthopedics. He returned to India in 1936. Now his determination to stick to orthopedic gave him a life of toil and troubles, and these are his own words. "I antagonized my own people at home for refusing to do general surgery. Public misunderstood my honest resolve as an inward fear to undertake general work, and some of them even contemptuously dubbed me a belly bone setter. Practice was extremely slow in coming, and existence was not infrequently humiliating. All doors were barred and bolted. I was not wanted anywhere." Now, this is his own admission. Fortunately for him, Sir N.S. Wadia had taken a bond from him when he sent him to England that he would serve the Wadia Children's Hospital for 3 years. So he returned in 36. In a few months, in May 1936, he started the first orthopedic department in India at the German Wadia Hospital for Children. This is a department which was then manned and managed by a fully qualified orthopedic surgeon. And that is why the first orthopedic department in India. Between 1938, 2 years after he joined Wadia Children's, 1938 he joined the BJ Children's Hospital, which is a part of the JJ group of teaching hospitals, as a pediatric surgeon, doing both general surgery and orthopedics, in the hope that an orthopedic department could be started in the main JJ hospital. But this was not to be. Again, in his own words, he said, "I stood resolutely to my specialty, and while doing such a lot of general surgical work in this hospital, stoutly refused to touch a single such case in private practice. My 3 years at this hospital were very rewarding." Dr. Kathrak's dreams were fulfilled when the KM hospital actually wanted to start an orthopedic department. Dr. Jivraj Mehta, who was then the dean and a powerful person in KM hospital, invited Dr. Kathrak to join this department in 1940. At that time, Dr. Kathrak was very happy with his appointment at the BJ Children's Hospital. He politely declined. But when things did not work out at JJ Hospital, he went back to Dr. Jivraj Mehta and asked him if he could be a part to open a orthopedic department at KM Hospital. So 1942, Dr. Kathrak joined the KM Hospital, and this was the first orthopedic department in a teaching hospital. That's how orthopedics started in India. Dr. A.K. Talwalker had joined KM Hospital 2 years before Dr. Kathrak, but very graciously he reverted as an assistant to Dr. Kathrak, and together they ran the department. At this point in time, Dr. Talwalker didn't have orthopedic qualifications, so the orthopedic department rightfully belonged to Dr. Kathrak. There was then, after Dr. Kathrak and Dr. Talwalker working together, there was a distinct improvement in morbidity of compound fractures, something you've been discussing. Amputations disappeared. 1949, Kunsha nailing and plating was started by Dr. Kathrak. Spinal fixation with plates and bolts. And fracture table, the department acquired a fracture table and a 30 MA X-ray machine, and Dr. Kathrak was overjoyed. Increasing workload eventually bifurcated these units. Dr. Kathrak was approached by Mrs. Kamala Limkar. She was an American citizen at that point in time, to start an occupational therapy center. Dr. Kathrak convinced the authorities, and OT took shape in 1950 at KM Hospital. Rehab center was brought in by UNESCO team, impressed by Dr. Kathrak's work, and physiotherapy took shape in 1953. And thus began OT and PT in India. Later events, 1953, Sir Henry Osmond Clark visited Mumbai, and it has some implications, I won't mention those. 1958, Dr. Kathrak retired from KM Hospital. However, he proposed an orthopedic center at KM Hospital, and in 1964, the Durmal Bajaj Orthopedic Center came into being. Between 1958 to 1963, Dr. Kathrak was Emeritus Professor of Orthopedics at the Sion Hospital Medical College. 1964, he was elected an Honorary Fellow of the British Orthopedic Association. 1965, in his honor, on his election as a Fellow of the British Orthopedic Association, the Bombay Orthopedic Surgeons got together and started this society in 1965 with Dr. Kathrak as the first president. In 1966, the first VIROC was held. The first Katrak oration was given by Dr. B. Mokopardya on use and abuse of metal. So the legacy of Dr. Rustam Jamshedji Katrak. Before his advent, the word orthopedics was virtually unknown. Before he died, he had the satisfaction of knowing that it had become a household word. These are the words of Dr. K.S. Masalawala in 1989. And Meredith very rightly says, that man is great and he alone, who serves a greatness not his own. The next part of my talk is on establishing pediatric orthopedics as a specialty. Now, there were many early orthopedic surgeons who practiced pediatrics, and I mean respect to all of them, you know. They are the forerunners in the field. Dr. Kathrak wrote on children, I strongly feel that children's hospitals should be separate. Children required a kind of attention not possible in a busy driving adult place. This is infinitely more so for orthopedic cases. Bombay requires an extremely strong pediatric setup. The pediatric setup came about with the Children's Orthopedic Hospital in 1948-49, and Dr. M.G. Kinney, who was in fact the first MCH Orth from the Liverpool University in 1929, but practiced general surgery and orthopedics, and therefore was not an exclusive orthopedic surgeon. Dr. M.G. Kinney was appointed after his retirement as the medical director in 1949 of the Children's Orthopedic Hospital at Haji Ali. So between 1949 to 1952, he was the medical director of the Children's Orthopedic Hospital. Dr. M.G. Kinney was a distinguished surgeon. He wrote a number of articles right from 1938 till his death in 1952. This is his paper on fractures of the lateral condyle of the lower end of the humerus with complications in 1942, published in the Journal of Bone and Joint Surgery. In Chennai, Dr. Kinney's successor was Dr. N.S. Narasimhan, and he also wrote a lot on fracture neck femur in children, bone and joint lesions in smallpox, on statistics on anterior poliomyelitis in India, and quadriceps contractures. These are all between the 30s and 40s. After the Second World War, the government of India felt that orthopedic surgeons were really necessary because of so much trauma and war casualties, you know. So between 1946 to 1949, the government offered scholarships to people who wanted to specialize, surgeons who wanted to specialize in orthopedic surgery, and 6 surgeons were selected: Dr. A.K. Talwalker, Dr. K.S. Grewal, Dr. B. Mokopardya, Dr. A.K. Saha, Dr. K.T. Dolakia, and Dr. P.K. Durai Swami. Here are the 6 of them, the pioneer orthopedic surgeons of that era. Dr. A.K. Talwalker was more interested in adult surgery, adult orthopedics, though he had a huge series on fracture neck femur in children. The second person is Dr. K.S. Grewal. On the right is Dr. Mokopardya. Below left is Dr. A.K. Saha. In the center is well known to all of you. On the right is Dr. P.K. Durai Swami. Dr. K.S. Grewal, after finishing his MCH, he returned in 1949 to start the Orthopedic Department at Amritsar, and he was one of the main architects of the orthopedic movement in India. He was president of the orthopedic section of the Association of Surgeons of India in 1960. And he published a lot of pediatric papers, and he devised this half tibialis anterior transplant in the management of congenital clubfoot in children. He wrote extensively on sequelae of poliomyelitis and on many other areas of pediatric orthopedics. Dr. P.K. Durai Swami was internationally acclaimed for his researches in teratogenesis done while at Liverpool in the late 1940s and early 1950s. And his most significant paper of 1952 on the experimental causation of congenital skeletal defects and its significance in orthopedic surgery. Professor A.K. Saha was well known all over the globe for his contributions to the understanding of the shoulder joint and his tendon transfers for poliomyelitis. On the right is a supplementum produced by the Acta Orthopedica Scandinavica in his honor on surgery of the paralyzed and flailed shoulder. Dr. B. Mukhopadhyay was another giant orthopedic surgeon, architect of the Indian Orthopedic Association, founder secretary of the Indian Orthopedic Association from 1955 to 1963, president of the Indian Orthopedic Association in 1964, president of the Association of Surgeons of India in 1970. And besides his work on clubfoot and TB spine, he did a lot of experimental work, and 2 of his papers are here. diaphyseectomy, and bone regeneration. And this is done with Dr. M.T. Mehta, who was his first postgraduate. Observations of the growth of epiphyseal bone transplants in guinea pigs. This was published in the 1950s, 60s. Dr. Talwalker is very well known in this part of the world. While a generalist at heart, he specialized and did significant work in initiating and developing scoliosis surgery in the 1970s. Besides joint replacement, in relation to pediatric orthopedics, he developed scoliosis surgery in the 1970s. Interestingly, he started his career as a surgeon superintendent at Children's Orthopedic Hospital. So under Dr. M.G. Kinney, Dr. Talwalker worked there as a surgeon superintendent at COH on his return from England. So 1949 he returned and he joined the Children's Orthopedic Hospital. Dr. Talwalker was the president of COT between 1978 to 1981. Now, a few slides on my boss, Dr. P.K. Mullah Firoz, Dr. Perrine K. Mullah Firoz, long innings of 95 years. And I always felt that to look further, we always stand on the shoulder of giants. She was the medical director of COH after Dr. M.G. Kinney, FRCS from England, surgeon and later head of orthopedics department at Sir J.J. Hospital. So speak about woman equality. She was the head of orthopedic department at Sir J.J. Hospital between 1948 and 1952. She was a lieutenant colonel and a World War II veteran. She saw action in the eastern part of undivided India and Burma and was awarded the Order of the British Empire. Her interest in pediatric orthopedics and rehabilitation prompted her to join the Children's Orthopedic Hospital. She left J.J. Hospital for the COH. She established the first CP unit of India in 1963. My first introduction to cerebral palsy was in 1980, working with her as the registrar at the Children's Orthopedic Hospital at Haji Ali in Mumbai. Another pioneer in this part of the world was Dr. B.B. Joshi, and his work on JES is very well known. The pediatric applications of his fixator are very, very well known, and I will not dilate. With the early pioneers, the stage was set. Of course, there were many more pioneers. I really can't go into each and every name. The stage was set for the development of pediatric orthopedics as a specialty. These forerunners deserve full credit, They deserve full credit for what came about later. All that was required was for somebody to take the onus to drive this as a specialty, to drive pediatric orthopedics as a specialty. I'll next talk on the development spread and some personal accomplishments. So I was keen to specialize in pediatric orthopedics as I loved children and spending time with them. In 1980, I had worked as a registrar at the Children's Orthopedic Hospital. My chance came in 1985 when, on an Indian Orthopedic Association fellowship, I spent the larger part of the year in Yokohama, Japan, on a pediatric fellowship. On the left is the Children's Orthopedic Center in Yokohama, where I worked in 1985. The center pain, my boss and me, in Yokohama. And 25 years later, I visited, of course, I kept meeting him, but I visited Japan as the president of the Indian Orthopedic Association and met with my boss, and the picture on the right is that picture. On my return from Japan in 1985, I came back to the Saha Hospital. I set up a specialized pediatric orthopedic OPD and ward, and for this, I am very grateful to Dr. N.S. Lord, who really encouraged. He had a progressive mindset, and he said, yes, Ashok, go ahead. This is your OPD, and this is your ward, 6 beds. We had a pediatric ward in a side room. This OPD flourished within a very short time. I was then appointed to both Wadia Children's and Children's Orthopedic Hospital as an honorary between 1986 and 1987. Dr. Subhash Dalal, Dean of the B.J. Wadia Hospital for Children, and Dr. Mullah Firoz, Medical Director of Children's Orthopedic Hospital, were veritably the guardian angels of pediatric orthopedics. In 1988, I got a chance to work a full year at the Alder Hey Children's Hospital, Liverpool, while pursuing the MCH Orth. This is where actually, in fact, I had started this work much before on sequelae of septic arthritis of the hip, which was a big problem in those days. But this is where the work was recognized and got the Norman Roberts Medal of the University of Liverpool, and of course the Best Treatise Award of the Bombay Orthopedic Society in 1989. Then we were working on scoliosis, and I was very interested in scoliosis, so anterior release for scoliosis. This won the Dr. A.K. Talwalker Best Paper Award in 1991, the Bombay Orthopedic Society Best Paper Award. Now, all this made an impact for pediatric orthopedics in those days because people felt what is there in pediatric orthopedics. My journey in scoliosis was a very long one, starting with H-rod instrumentation and Lukey instrumentation, then anterior surgery for scoliosis. I modified the Zielke apparatus, which was then used by Shekhar and many other people for anterior surgery. Between 1990 and 1995, I worked with Dubusse of the CD Cottrell Dubusse fame and introduced the posterior derotation system or the multi-segmental system in India, the Lukey trolley and growth rods. In 1995, we devised the anteroposterior single incision to reach the front and the back of the spine in children. 1996, I took to endoscopic anterior spine surgery, and we held a national conference somewhere around that time, 96 or 97. 2000, I worked on incidence of spinal dysraphism. 2007, introduced the Vector, and 2014, the magnetic distraction rod, growth rod for spine, and also the precise for limb lengthening. Now, at this time, I was also working on an indigenous distractor for limb reconstruction, and this won the Dr. A. Mehta Gold Medal Award in 1993. This was a very simple conversion of Elizaro principles to a uniplanar fixator to perform most of the applications of the Elizaro fixator. And this is an example from 1989, a case of congenital pseudarthrosis of tibia, bone transportation, distraction, and then getting a complete gap filled in, getting it to heal. And that was the fixator, a very, very simple fixator costing about 100 rupees in those days. But one sees that there is valgus present at that ankle joint. We were not very conscious of this at that time. So we did a deformity correction using a similar frame. And this is deformity corrected and the ankle horizontalized. This is 7 years after the initial attempt and a 14-year follow-up. The bone has healed well and the ankle is horizontal. Some other contributions. Does this give you an idea? The Indian dance format, Gliding, which happens with the Bharatnatyam and Kathak dances. This won the Silver Jubilee Commemoration Award of the Indian Orthopedic Association. This was a word we coined as the lateral gliding movement of the neck. So this is lateral gliding movement of the neck. This was not well recognized, still is not well recognized. What is lateral gliding? The questions, what is it? Where does it occur? How can it be measured? What is the range? And what is its utility? So this is lateral glide. Going from one side, the neck moves from one side to the other side. This is lateral gliding. How does it occur? So this is what happens, We've done CT scan pictures here to see what is happening. A lower cervical scoliosis is produced opposite the side of the glide. So if you are gliding to the left, you have a right-sided lower cervical scoliosis, then a transitional zone, and a mid to upper cervical scoliosis convex to the side of the glide to get your head back to the center. We can measure it. The center diagram is the zero position. On the left, this was a very simple instrument we devised. The left side glide. On the right is the right side glide. So the central pointer from the chin and a central mark on a scale which is kept there. And you can do a reading as to how much is the glide measurement. So when we talk of age, the lateral gliding improves over time. And it can extend to 6 to 7 centimeters when a child becomes an adolescent. Now, what application, what is the importance of this, In torticollis, where you have a shortened sternocleidomastoid, if your sternocleidomastoid is short, the neck cannot glide as much, And here is an example on an X-ray. Right-sided torticollis, the sternomastoid length is 7.5 centimeters from the occiput to the manubrious sterni. And from the midline, the glide is 1.8 centimeters. On the right side, which is the normal side, the glide is 5 centimeters. And the sternomastoid length is 12.5 centimeters. These are all measurements done by Alaric. He's sitting here. Long ago, So this is the glide to the left and to the right. It has a very simple basis. If you know the theory of Pythagoras or the theorem of Pythagoras, your hypotenuse, the longer the hypotenuse, the longer will be the base. The longer the hypotenuse, longer will be the base, which is shown by the arrow. If your sternomastoid is contracted, you have a small sternomastoid, so the base is small, and that is why the glide is small. If your base is larger, the glide is larger. This is a very sensitive test to detect and post-operatively treat torticollis. The Pediatric Orthopedic Society of India was formed in 1994, and the beginning was a friendship between me and Dr. Benjamin Joseph. Both of us were interested in pediatric orthopedics right from the 1980s, and then we conceptualized. Eventually, this was formed in 1994. At the POSI inaugural, we had all the eminent surgeons of that time. The first POSI EC was with Dr. Varghese Shako, Benjamin's boss, as the president, Dr. Tarapurwala, my boss, as the vice president, myself, Dr. Benjamin Joseph, and on the right is Professor Sriram, again, very interested in pediatric orthopedics and one of the middle order pioneers of pediatric orthopedics. POSI has now become one of the leading pediatric orthopedic societies in the world today. It is the second largest pediatric orthopedic society after POSNA. It celebrated its silver jubilee in 2019. It's going from good to great. And the history of POSI has been written up in a book which actually details everything between 1994 to 2019. So pediatric orthopedics, the field covering the whole gamut of children's orthopedics, has blossomed into a major specialty with many budding leaders in the next generation. So ours was the first sort of generation, but now we have many budding leaders in the next generations. Many researches have been carried out and published by the pediatric group. Benjamin Joseph has done extensive work on congenital pseudarthrosis of tibia, osteogenesis imperfecta, and monumental work on Perthes disease, ably continuing under his successor, Dr. Hitesh Shah. Many techniques have been refined and pioneered. Translational research is being carried out at CMC Vellore. The younger group of specialized pediatric orthopedic surgeons are branching out into special fields of interest. On the international scenario, since 2006 end, actually, I have had the privilege of being the chief editor for this prestigious international journal, the Journal of Pediatric Orthopedics. B stands for the British volume, actually. Now, we have to pass the torch, and these are the leaders of tomorrow. Some of them are already leaders, today. But this is the importance of mentoring and passing on the torch and creating your next generation of specialists, creating the next generation in pediatric orthopedics. The last part of my talk is on pediatric orthopedics in India and what is its future. Where are we marching? What is the future of pediatric orthopedics in India? Well, this is like making prophecies which may become untrue or which may become true. On the other hand, there is a 50% chance. I would just like to focus very briefly on 3 or 4 points. The question is, where should we focus? 4 areas: patient care and practice, delivery of healthcare and manpower, education and training, and research. In patient care, I think the focus has to shift from surgery to early detection by screening. Example for DDH. We see so many neglected cases of DDH. We see so many problems with CP hips which migrate, which are unstable potentially, and which migrate out. So the focus has to be on early detection for a number of reasons. Then outcome studies and critical research. Whatever we are doing, is it changing the health-related quality of life in any way? We are doing our procedures, but is it making an impact on the patient. More so in cerebral palsy, this is happening. We need to study the outcome research has to be done. Then we need to study the evidence-based treatments and minimally invasive interventions. And genetics and biomechanics are going to be strong forces for the future. Now, public health priority is prevention and control of disease. This is the most cost-effective approach and should be our priority. And the futility of surgery, one would realize if one were to see polio. We are operating polio left, right, and center, but polio was eradicated not by surgeons, but by prevention, by vaccination, and by a great social and governmental effort. So screening, we are at that situation. Al asked me to write this editorial for the Indian Journal of Orthopedics, why the time is ripe for India to develop a national DDH screening program. Because we are getting so many neglected DDHs, we are operating them left, right, center, when that could be prevented, We can screen them early and we can detect them early, treat them by simple treatments. CP-hip is another case in point. The Indian scenario is alarming. We have 2.5 million pool of cerebral palsy patients in India, and a 35% incidence of hip instability is quoted, which equals 800,000 patients, and 15% incidence of dislocation, which means 375,000 hip dislocations. If we quote the Western figure and the Western incidence, I don't know if this is right for India, but yes, this should be right very, very closely. So another editorial on Save the hip surveillance in cerebral palsy is the need of the hour. Now another issue we have is the delivery of healthcare and what is our workforce. POSI members are 700, of which pediatric orthopedic surgeons are about 100, 14%. General orthopedic surgeons in India are about 13,000 or maybe more than that, officially 13,000. The load per pediatric orthopod, if you have 100 pediatric orthopod for a 500 million population of children, per pediatric orthopod we have 5 million children to cater to. This is a huge, huge load. But where is our workforce? Rural areas is 0. Semi-urban to urban areas is 100%. So the rural population is just not catered for. The geographic distribution, even in advanced countries like the US, is not an equitable distribution. And pediatric orthopedic surgeons cannot reach many parts of the population where they are desired. In fact, they reach only about 65% of the population which needs their services. So the workforce of pediatric orthopedics is woefully inadequate. The distribution of the pediatric orthopedic workforce is terribly skewed with no coverage for the rural pediatric population. So how should we make pediatric orthopedics attractive for the young surgeons? We do have some solutions. I really don't want to go into this. But for the future, manpower development is a priority. Wider coverage, possibly universal for all pediatric orthopedic problems. Referral linkages with coverage of the rural population. The government is trying that through the Rural Health Mission. Efficient delivery of health care to reduce morbidity due to delays and late diagnosis. The last part is education and training and research. Education of the pediatric orthopedic surgeons, something we have to focus on. Most of them are indigenously trained today. Some are trained abroad in certain parts of pediatric orthopedics, but structured fellowships are the only way. Fellowships have increased recently. They have tremendously increased compared to the past times. And now an MCH degree course is available in pediatric orthopedics. The education should have a thrust on prevention and on conservatism. I think this is very, very important. Research needs to be relevant. The language of research needs to be mastered by all. This is important again for our undergraduates and for the young surgeons. So the future of pediatric orthopedics in India, catch them early, catch them young. The future of pediatric orthopedics in India is particularly bright because the huge pool we have, huge pool of patients we have. So in honor of Dr. R.J. Kathrak, I would say that the legacy of Dr. R.J. Kathrak lives on, and it's going to live on. There's no question, it's going to live on for ages, times immemorial. This is going to happen, and we are here to honor his memory. I would just say in my last slide, what is the future soon becomes the present. What is the present soon becomes the past. The present is the bridge connecting the past and the future. Let us work today, for this is the present, the creator of the past and the future. Thank you very much for your attention.